Stroke patients are at an increased risk of cardiovascular disease, so before commencing any exercise testing or prescription, I would refer the patient to have a cardiac stress test with ECG to detect any signs of myocardial infarction. I would recommend a YMCA cycle ergometer protocol adapted for use on a total body recumbent stepper because this is more comfortable, which is particularly relevant considering Robert is obese, and it has also been found to be more appropriate than a treadmill or cycle erg for patients with a variety of physical deficits. This adapted protocol has been found to be valid in predicting VO2 max in older adults with various chronic conditions. The goals which the GP has set out, which are specifically relevant to myself as the AEP, are to increase Robert's exercise capacity, improve his functional ability, and improve his balance. Robert's chief complaints are his reduced ability to walk and balance, which are affecting his independence, and also his right arm weakness, which affects his ADLs, such as carrying objects. In relation to health-related physical fitness, movement capacity, and functional ability, as well as the TCA goals and the client's chief complaints, I've selected these 4 tests: Berg's balance scale, a step test, grip strength, and a 2-minute walk test. Berg's balance scale is a 14-item objective measure including static and dynamic balance activities of varying difficulties. You need a stopwatch or a watch with a seconds timer, a ruler or anything to measure 2, 5 and 10 inches, a chair of reasonable height, and a step or stool which is the height of an average step. As long as the chair and step that are used are the same when retested, it will be a reliable test. For each item, a score of 0, 1, 2, 3 or 4 is given, depending on the participant's ability to perform the task. Detailed instructions on how to score each individual item are available online. A score of 0 indicates the lowest level of function, while a score of 4 indicates the highest level of function. All of the item scores are added together to form the total score for the assessment, which can then be interpreted. The BBS has strong reliability, validity, and responsiveness to change. It has also been found to be useful, easy to administer, inexpensive, and time efficient. However, it has also been found to have floor and ceiling effects and is unable to detect meaningful change in mild or severe cases, and so it's been recommended to use another balance assessment tool in conjunction with the BBS to address these floor and ceiling effects. This table shows Robert's scores for the Berg balance scale and his total score of 25. The mean Berg balance score for community dwelling adult males aged 70 to 79 is 54 out of 56, according to Stefan et al. 2002. There have been many different cutoff scores reported for increased falls risk, but regardless of which ones you look at, Robert's score of 25 puts him at an increased risk of having a fall. This brings me to the step test. This is a tool used to assess dynamic balance. Equipment needed is a 7.5 centimetre step and a stopwatch or a watch with a seconds hand. The individual being assessed is asked to place one foot on the step and then fully back down on the floor repeatedly as fast as they can for 15 seconds. The opposite stance leg is to remain stationary. The examiner counts the number of steps completed in 15 seconds for each leg, and this number becomes their score. If the participant overbalances or needs steadying during the test, the examiner is to stop counting and the number of steps completed prior to losing their balance is recorded as their score. A video recorder can be used to ensure step counting is accurate, and this test has been found to be reliable regardless of the level of experience of the examiner when using videotapes to count the steps. There is normative data available for the step test in chronic stroke patients, and it has been established for use with stroke patients as it is reliable, valid, and sensitive to change during rehab. Results correlate well with lower limb muscle strength, walking speed, lower limb motor coordination and balance, which tie in well with the GP's goals and the client's chief complaints, and the test has high retest reliability in stroke patients specifically. It's easy to conduct with minimal equipment needed, and another thing to note is that if the patient is unable to stand unsupported for any of the items, they'll receive a score of 0 for that item. This table presents Robert's scores, and as you can see, he scored lower on his paretic right side than on his left side. The lowest score of the two legs is used for interpretation. A score of less than or equal to 7 suggests falls risk post-stroke. Robert scored 5 on his paretic side, so he's at an increased risk of falls. This slide outlines the protocol for assessing grip strength with the hand grip dynamometer. Scoring is based on force produced in kilograms or pounds. The score recorded is a maximum grip and is the mean of 3 trials. Grip strength is a quick, objective, and easily implemented measure. The reported reference values for this measure allow for the differentiation between subjects of any age and sex, and the clinical identification of muscle weaknesses and adequate therapeutic planning. Moderate to high correlations exist between grip strength, measured with a hand grip dynamometer, and upper limb performance measures. Low muscle strength is associated with poor lower limb physical function as well, so grip strength is a good indicator of global physical function. So we can see from this results table that Robert's grip strength in kilograms on his affected side is significantly lower than the age and gender match norms established by Massey, Westrop et al. 2011. We can also see that his grip strength on the unaffected left side was significantly lower compared to those norms. This is consistent with findings of a study by Park and Park 2016, which found that grip strength on the unaffected side of patients with hemiplegia was significantly lower compared to that of patients in the normal control group. These findings suggest that interventions should focus on both the unaffected and the affected sides. This slide outlines the setup for a 2-minute walk test, which is a 30-metre walkway cleared of obstacles, and listed there is the equipment needed. Overall time to administer is 4 minutes, and assistive devices can be used but must be kept constant during retesting. Also, the instruction and encouragement throughout the test must be standardised. As the assessor, you will explain to the participant that the objective is to walk as far as possible along the 30-metre track for 2 minutes. You'll also explain that they may slow down if necessary, and that if they stop, they should begin walking again as soon as possible. So if they do need to stop, you can get them a chair, check their heart rate and blood pressure if you have access to that equipment, ask them why they've stopped, keep the timer running, and ask them to begin walking again when they are able. You will instruct the participant not to talk during the test unless they have a question or concern, and inform them that they must let you know about any chest pain or dizziness. Explain that when the 2 minutes is up, you will tell them to stop where they are. Then you'll ask if they have any questions before you begin the test. You'll then instruct the participant to start when they're ready and start the timer when they begin. The participant will walk up and down the marked track for 30-metre track for 2 minutes. When the 2 minutes is up, instruct the participant to stop where they are. Use the trundle wheel or tape measure to measure the distance from the end of the track that they were last at to the point where they stopped. This distance is then added to the number of laps that they have walked times 30 metres to find the total number of metres walked. At the end of the test, record the distance walked and measure and record the participant's RPE using Borg's RPE scale and their heart rate using a heart rate monitor, or by taking their pulse measure. Due to the calcium channel blocker and nitrate that Robert is taking, his resting and exercise heart rate may be raised and blood pressure lowered, so RPE may be a more useful measure of intensity for exercise testing and prescription than target heart rate. The 2-minute walk test is a measure of submaximal cardiovascular endurance, which has been adapted from the 6-minute walk test. It's a measure of aerobic capacity, functional mobility and gait, all of which are relevant to the GP goals and Robert's chief complaints. It has been found to have excellent validity, test-retest reliability, and inter-relator and intra-rater reliability. Due to his level of function, a 2-minute duration is much more appropriate for Robert than a 6-minute duration, and since the results of the 2-minute correlate highly with those of the 6 minutes, this is a more appropriate test. The mean number of metres walked for healthy males in Robert's age group is 157, so Robert's score of 135 metres walked puts him in the lower 25% of scores for his age and gender. Robert's RPE at the end of the test was 15 on the RPE scale, which is right about where we want him to be. The readiness to change ruler assesses a person's willingness or readiness to change a behaviour, determines where they are on the continuum of not ready to change or already changing, and also promotes the identification and discussion of perceived barriers. When asked, Robert identified that he's a 6 on the readiness to change ruler. As recommended by Zimmerman et al., I then asked Robert what barriers are preventing him from being further to the right on the ruler, and what motivators are stopping him from being further to the left, and I've listed these in the table. This table lists the actions that can be made to overcome the barriers. This table outlines the goals that Robert and I have set for the 12-week rehab program. We've set a specific goal to increase his BBS score from 25 to 30 by week 6, and another goal to increase the BBS score from 30 to 35 in week 12. We'll measure the progress towards both of these goals with the BBS, and at 6 weeks after repeating the BBS, the 12-week goal will be re-evaluated depending on how he's progressing so far. We've set specific goals to increase the step test score to achieve 7 or more on each leg by week 6, and another goal to achieve 10 or more on each leg by week 12. Progress towards these goals will be evaluated by the step test, and again, the week 12 goal will be re-evaluated pending 6-week results. We've set a goal to increase the 2-minute walk time from 134 to 144, so a 10-minute increase at 6 weeks, and then a goal to add a further 10 metres to the 2-metre walk score from the 6-week result, in 12 weeks. Progress towards the goal will be measured with the 2-metre walk test. We have set a goal to improve grip strength by 3 kilos on both the left and right by 6 weeks, and then a further 3 kilograms on the left and right by 12 weeks. The 12-week goal will be re-evaluated at 6 weeks, and progress will be measured with the handheld dynamometer. For the aerobic component of the exercise program, Robert and I have set out a realistic plan for him to progressively increase the number of minutes he spends exercising per week until he achieves the minimum recommended amount of 150 minutes of moderate intensity activity per week, as recommended by Sim et al. The report by Sim et al. Defines moderate activity as that which makes the heart beat faster but you're still able to talk comfortably. So I'd explain this to Robert and encourage him to use the talk test to monitor his intensity while walking. The report also says that some exercise is better than none, and inactive people should start where they are with whatever they can manage and gradually work their way up to the minimum recommended amount of activity. Having a large 4-week initial phase where we're not progressing with the program is aimed at improving Robert's self-efficacy through allowing him to feel like he's mastered the program before we begin to challenge him. This is in accordance with Bandura's theory of self-efficacy. Robert will participate in 2 supervised aerobic training sessions per week. So this, along with his other aerobic training, will add up to the recommended 3 to 5 days of aerobic training per week. It will be treadmill walking due to the transference and generalizability of the training effects, and he will be able to use the handrail support, and the exercise intensity can be adjusted by either speed or gradient. An RPE of 11 to 13 will be used. RPE is more useful than heart rate as a measure of intensity due to the medication increasing his heart rate, and also due to the biomechanical impairments being a predominant factor limiting Robert's performance. This table outlines the way the supervised treadmill walking will be progressed throughout the program. Interval training may be utilised to improve exercise tolerance if the target amount of minutes cannot be completed in one go. Having a large 4-week initial phase is again aimed at improving Robert's self-efficacy. Now to the balance program. As mentioned on an earlier slide, balance is an important component of optimal function for locomotion and activities of daily living. So again, we have the initial 4-week phase to build his self-efficacy. We have 4 very simple exercises for Robert to complete at home daily. I would explain and demonstrate each exercise to Robert and assess the safety of him completing these exercises unsupervised at home during his first visit to the clinic for his resistance and cardio session. In week 5, we'll begin to progress gradually as tolerated, explaining to Robert he always has the option to regress if needed, and he's not obligated to progress if he doesn't feel safe. In week 7, we step it up again and move from seated exercises to standing if Robert feels comfortable and safe to do so. Again, I'll go through these exercises with him in the first supervised session of week 7 and instruct Robert not to try them at home until after the session to ensure that he's ready. Week 9 to 12 are the maintenance phase where he can further master the skills and improve his self-efficacy to hopefully promote adherence. Resistance training will occur on 3 days per week, including all major muscle groups. The intensity is set at a 3 to a 5 on Borg's CR10 scale, as this score has been found to fall within the 60 to 70% of estimated 1RM range. And according to ACMSM's guidelines for CVD patients, we want to be training at about 40 to 60% of the 1RM. The initial 4 weeks of the program will consist of 1 set of 10 reps of each exercise performed at 40 to 60% of Robert's 1RM. In these 4 weeks, he'll be learning, practicing and mastering the correct technique for each exercise and gaining confidence or self-efficacy in accordance with Bandura's theory. In week 5, the first week of the progressive phase, we'll increase sets from 1 to 2 and allow 2 minutes rest between sets for full recovery. All other variables will remain the same. In week 6, we'll progress further by decreasing the rest interval from 2 minutes to 90 seconds. All other variables will remain the same. In week 7, we'll progress by reducing the rest interval from 90 to 60 seconds. All other variables will remain the same. And the final progression in week 8 is the addition of a 3rd set of each exercise. All other variables will remain the same. The very gradual progression of the middle 4 weeks of the program aims to reduce the risk of overtraining and causing severe DOMS or fatigue. The program should only be progressed as tolerated and regressed if needed. For example, if Robert experiences severe DOMS and fatigue and can't get out of bed after a training session, we'll allow adequate rest and recovery, and then increase the rest, reduce the number of sets, or decrease the resistance for the next session. In weeks 9 to 12 of the program, Robert is to continue with the 3 resistance sessions per week. The only variable that may change during this time is the resistance used to ensure that the intensity remains as a 3 to 5 on the Borg CR10 scale. The maintenance phase will once again allow an opportunity for Robert to feel he has mastered the exercises, to improve his self-efficacy, and hopefully promote adherence to longer-term exercise participation. Flexibility training will be 3 days per week after each resistance training session. The goal is to improve range of motion of the involved extremities and prevent contractures. Emphasis should be on the paretic side, particularly muscle groups experiencing spasticity. Often this is the flexor muscle groups rather than the extensors.